Good morning, everyone, and thank you for being here today. My name is Dr. Asim Haseen, and I am pleased to welcome you to this presentation on endocrine and metabolic emergencies. Today, we will focus on a critical condition known as thyroid storm. We'll explore what it is, how to recognize it, and the best ways to manage it effectively. I'm excited to share this important information with you, so let's get started. All right, let's look at this question carefully. We have a 58-year-old man with known thyrotoxicosis who's suddenly become acutely agitated, febrile at 40, 2 degrees C, hypotensive, and an atrial fibrillation after hip surgery. These signs indicate a thyroid storm, which is a life-threatening emergency. The key here is understanding the correct sequence of treatment. The options list different approaches, mainly focusing on how to manage the excess thyroid hormones and the hypermetabolic state. In thyroid storm, the priority is to rapidly control the symptoms while preventing further hormone release. The most important initial step is to inhibit hormone synthesis and release, then manage the symptoms with supportive therapy. Looking at the options, the best approach is to start with antithyroid medications like PTU, which not only inhibit new hormone synthesis, but also block peripheral conversion of T4 to T3. After administering PTU, we typically give iodine, but only after the antithyroid medication has had time to work. This prevents iodine from being used as a substrate to produce more thyroid hormones, which would worsen the situation. Finally, propranolol is given to control the adrenergic symptoms, like tachycardia, agitation, and tremors, and also reduces peripheral conversion of T4 to T3. But we never give propranolol before antithyroid drugs because it could potentially worsen the release of stored hormones. So the correct sequence is giving PTU first, then iodine after about an hour, and then propranolol. That corresponds with option C. This sequence is critical because it maximizes treatment effectiveness and minimizes risks, ensuring we stabilize the patient as efficiently as possible in this emergency. Let's walk through the key points here. The correct answer is C, and the main idea is about the sequence of treatments in managing thyroid hormone overload. First, you want to inhibit new hormone synthesis, and the preferred agent for this is PTU, or propylthuracil. The reason is that PTU not only blocks the synthesis of new thyroid hormones, but also inhibits the peripheral conversion of T4 to the more active T3. After you've started this step, you need to wait at least an hour before administering iodine. The purpose of iodine is to block the release of preformed thyroid hormones into the circulation, but giving it too early can actually worsen hormone production if the gland is still synthesizing hormones. Now, in addition to these primary treatments, beta blockers like propranolol are used as adjuncts. They help control symptoms such as tachycardia and tremors. Glucocorticoids can also be administered to reduce the conversion of T4 to T3 and to manage potential complication risks. The sequence really matters here. First, inhibit synthesis, then block hormone release, and finally add supportive medications. Understanding this order is crucial for effective management in hyperthyroid emergencies. All right, let's look at this question. We're dealing with a patient in thyroid storm who has significant tachycardia, but their blood pressure is borderline, and there are signs of low cardiac output. The key here is to identify the safest beta blocker strategy given these specific conditions. Now, option A suggests a large IV propranolol bolus, but that's probably too aggressive in this setting because it could potentially worsen the low cardiac output or cause hemodynamic instability. Option B recommends an esmolol infusion titrated to rate. This is often preferred in unstable patients because esmolol has a very short half-life, allowing us to control the heart rate carefully and make adjustments quickly if needed. Option C involves giving oral propranolol stat, but in a situation where immediate control is needed, oral administration may not be fast enough or safe, especially with borderline blood pressure. Option D suggests avoiding any beta blocker entirely, but in thyroid storm with tachycardia, controlling the heart rate is crucial to reduce cardiac stress. And finally, option E is giving a metoprolol bolus IV, which is an option, but again, it's less titratable compared to the continuous infusion of esmolol, especially in unstable patients. Overall, the safest approach here is to start an infusion of esmolol, titrated carefully to the heart rate, because it allows us to manage the tachycardia without risking sudden drops in blood pressure or cardiac output. This strategy aligns with the overall goal of stabilizing the patient while minimizing hemodynamic risk. Let's look at this question carefully. The correct answer is B. When managing hemodynamic instability or borderline blood pressure, it's important to choose the right medication. Here, a short-acting, titratable agent like esmolol is preferred. The key reason is that it allows us to adjust the dose quickly, and if needed, stop the medication promptly if we see that the patient's blood pressure drops too much. This flexibility is crucial in unstable situations. On the other hand, administering large boluses of non-selective agents can be risky. They may cause a sudden drop in blood pressure, potentially leading to collapse. So, in these critical moments, choosing a drug that can be carefully titrated and stopped easily helps us maintain better control and avoid adverse events. This approach highlights the importance of tailored, cautious management in patients with unstable hemodynamics, which ties into our overall theme of safe and effective perioperative care. Now, let's focus on this scenario. A patient in thyroid storm who develops rapid atrial fibrillation with a ventricular rate of 160, but remains hemodynamically stable. The key question here is, what is the best approach to anticoagulation in this situation? First off, it's important to remember that in thyroid storm, the patient is in a hypermetabolic state, which can complicate management. When it comes to atrial fibrillation, especially with a high ventricular rate, anticoagulation is typically considered to prevent stroke. However, in this specific context, we need to be cautious. The options on the table are, do we wait until the patient is euthyroid before starting anticoagulation, or do we start full anticoagulation immediately? Or perhaps give aspirin only, delay anticoagulation for a week, or use a prophylactic dose of low molecular weight heparin. Most importantly, when the patient is hemodynamically stable, initiating full anticoagulation is generally advisable to reduce the risk of thromboembolic events. But because of the hyperthyroid state and potential bleeding risks, we need to balance these factors carefully. In this case, the most appropriate choice is to start full anticoagulation unless there are specific contraindications. This helps manage the risk of stroke effectively, especially given the high ventricular rate. Remember, this decision isn't made in isolation. It's part of a comprehensive approach to stabilizing the patient, controlling the thyroid storm, and preventing complications. So, in summary, for a hemodynamically stable patient with new-onset AF in thyroid storm, initiating full anticoagulation is generally the best course. The correct answer here is B now. Let's break that down a bit. When we're dealing with a thyroid storm combined with atrial fibrillation, the key concern is the increased risk of thromboembolic events. Essentially, the hyperthyroid state and the arrhythmia both contribute to a higher chance of blood clots forming and potentially causing strokes or other embolic complications. So the main point is that in such cases, we should start full anticoagulation right away, unless there's a specific contraindication. This means using blood thinners to prevent clot formation. At the same time, it's important to manage the arrhythmia and the storm itself. So treat the thyroid crisis aggressively and stabilize the patient's cardiac rhythm. This approach highlights a crucial concept in managing thyroid emergencies, balancing the immediate risks of the storm with the long-term risk of thromboembolism. And it emphasizes that prompt anticoagulation is a cornerstone of treatment in these complex situations. All right, let's look at this critical question about managing a severe thyroid storm with hyperpyrexia and encephalopathy. When dealing with such a severe presentation, aggressive treatment is essential. Now, among the options, the focus is on selecting the most appropriate steroid regimen. Option A suggests giving hydrocortisone 100 mg IV and repeating it every 8 hours. This approach is often used in adrenal insufficiency, but in thyroid storm, steroids are primarily used to reduce peripheral conversion of T4 to T3 and to stabilize the patient. Option B recommends dexamethasone only if the ACTH test is abnormal. While dexamethasone is a potent steroid, waiting for ACTH results might delay treatment in an emergency like this. Option C states no steroids, claiming they worsen hyperglycemia. However, in the context of a thyroid storm, steroids are actually beneficial and should not be withheld due to hyperglycemia. Option D suggests prednisone 5 mg orally daily, but this dose is relatively low and might not be sufficient in such a severe case. Finally, option E involves fludrocortisone 0.1 mg daily, which is primarily used for adrenal insufficiency, not for thyroid storm management. So, considering the urgency and severity, the most appropriate choice here is the use of hydrocortisone IV, given its rapid action and proven benefit in thyroid storm management. This aligns with our overall theme of aggressive, timely intervention in critical thyroid conditions. The correct answer here is A now. Let's talk through why that's the best choice. Administering hydrocortisone at 100 milligrams IV every 8 hours is crucial because it helps reduce peripheral conversion, which is the process where cortisol gets converted to its inactive forms. This way, we maintain effective cortisol levels in the body. Additionally, hydrocortisone supports adrenal function during severe illness, which is vital for patient stabilization. It's important to note, though, this treatment shouldn't be delayed. Prompt administration can make a significant difference in outcomes. So, understanding this approach helps us respond quickly and effectively in critical situations, aligning with our overall theme of timely, targeted interventions in severe illnesses. Now, let's look at this scenario. A patient experiencing a hypermetabolic storm with a persistent fever of 40.5 degrees Celsius, despite initial treatments like acetaminophen and cooling blankets. This situation indicates that we need to escalate our management approach. The key point here is that simply continuing with acetaminophen and external cooling isn't enough at this stage. We need to actively address the underlying cause and prevent further complications. The most appropriate next step in this case is to implement active external cooling combined with aggressive supportive care and to treat the underlying storm itself. This approach aims to control the hyperthermia more effectively and stabilize the patient. Remember, in such critical situations, timely intervention is crucial to prevent organ damage. This ties back to our overall theme of managing severe hyperthermic states or hypermetabolic crises, emphasizing that when initial measures fail, a more aggressive, multifaceted approach is essential. It's not just about cooling down the patient, but also about addressing the root cause and supporting vital functions. The correct answer here is C when managing hyperpyrexia. The key is to implement active external cooling to bring the temperature down quickly. Additionally, administering IV fluids helps prevent dehydration and supports overall stabilization. It's also crucial to identify and treat the underlying causes of the hyperpyrexia. Now, it's important to note that dantrolene is specifically used for malignant hyperthermia, a particular kind of severe hypermetabolic state triggered by certain anesthetics. On the other hand, aspirin is not recommended in this situation because it carries a bleeding risk, especially when the patient's condition is unstable. Overall, the main points are to cool the patient actively, hydrate appropriately, and target the root cause, while avoiding treatments like aspirin that could pose additional risks. This approach aligns with best practices for managing severe hyperpyrexia effectively and safely. Now, let's talk about thyroid storm, which is a severe and potentially life-threatening complication of hyperthyroidism. It can be triggered by factors like surgery, infection, or even stopping antithyroid medications. When this happens, patients often present with symptoms such as high fever, delirium or encephalopathy, rapid heart rate or atrial fibrillation, congestive heart failure, and gastrointestinal disturbances like nausea or diarrhea. The key to managing this crisis is prompt and systematic treatment. First, we start with antithyroid drugs, either PTU or methimazole, because they help block the synthesis of thyroid hormones. If PTU isn't available, methimazole is a good alternative. About an hour after giving the antithyroid medication, we administer iodine. The reason for this timing is to prevent iodine from being used to produce more thyroid hormone, so we give it after blocking hormone synthesis. Next, if the patient is unstable, we use a beta blocker such as esmolol to control the heart rate and reduce sympathetic symptoms. Following that, glucocorticoids like hydrocortisone come into play, which help decrease the peripheral conversion of T4 to the more active T3, and also support adrenal function. Supportive measures are equally important. These include fluid replacement for dehydration, cooling measures to reduce fever, and treating any triggers like infection. Additionally, we need to consider anticoagulation if the patient has atrial fibrillation, unless there's a contraindication. And we must be vigilant about monitoring for hepatic dysfunction, especially from PTU, since it can affect the liver. In summary, thyroid storm is a medical emergency that requires a coordinated approach to stabilize the patient and prevent serious complications. Thank you so much for your attention today. I really appreciate you taking the time to explore these ideas with me. This is the final slide, and I want to leave you with a simple but sincere message. Thank you. Your engagement and interest are what make these discussions meaningful and impactful. Remember the key points we've covered, whether it's the importance of innovation, collaboration, or continuous learning, are all interconnected and essential to our success. I encourage you to take these concepts forward, apply them in your own work, and keep the momentum going. Again, thank you for being part of this presentation, and I look forward to seeing how you implement these insights moving ahead.